Are we up now? Okay. Good evening, everybody, and welcome to the Health and Wellbeing Board. And welcome to our guests at the back. I hope you enjoy the meeting. And please, if at the end you've got any questions, don't hesitate to ask. Thank you. Apologies for absence, Bert.
Yes, Chair. We get apologies from David Carter. Substitute Liz is supposed to be joining us online. I'm not sure if she's doing yet. We get Alex House from Bedfordshire Police and Ian Howarth from Bedfordshire Fire.
Okay. Can we accept those apologies? Thank you. Minutes of the meeting of the 27th of June. Is that all right for me to sign as a true record? Thank you.
Yes, sure.
Remind members of disclosures of interest if you have any. We have no urgent business, I believe. We've no references from other committees or other bodies. And we're on to item 6, which actually is a retrospective approval that myself and Nina signed off a while ago. We're asking the Health and Wellbeing Board to approve that. It was to do with the Better Care Fund. Are there any questions, or is it okay to approve that? Okay, brilliant. Thank you very much, everybody. We move on to item 7, and the Q2 template. Who's taking that one tonight? Is that you, Sally?
It is.
Okay.
And whenever I move my laptop, it just crashes. So my laptop's crashed, but I've got something on my phone that I can just read. So the BCF quarterly reporting post-COVID has now been reinstated, and the report details successes and potential issues arising around the BCF metrics. So the Q2 report has asked for an update on the voluntary capacity and demand exercise which Luton is participating in, so that's included as well. Sheet 5.1 contains a narrative update including learning from the last 6 months and contingency plans should demand exceed capacity. The projections as we enter winter have been refreshed and are set out in sheet 5.2, and the Luton immediate care is projected to manage the capacity and demand during the winter months with established contingency plans in place. Although it must be noted that the impact of future strikes and potential uptick in flu could impact on acute flow, which would increase the pressure on the system as a whole. But hopefully the rest is clear and can be signed off.
Thank you, Sally. Are there any questions from anybody on the report? Are we happy to agree the recommendations? Agreed?
Yes. Agreed.
Thank you very much. We now move on to item 8, which is the Integrated Care Board update.
Thank you. So I've got a few colleagues around the table who may want to add, but if I just highlight a couple of elements. Specialist commissioning, it was just to make everyone aware, and just for clarity, specialist commissioning is those services that are low volume, usually high cost. However, there are a number of services that are more mainstream, just to give you that sort of illustrations: chemotherapy, dialysis, radiotherapy. So the agreement has been that BLMK will take on hosting specialist commissioning for our region, so we will continue it as a region. And really, I think it's very, very good news, particularly for Luton, because a number of our residents are probably shortchanged, particularly in those areas. So it's really trying to integrate it with mainstream, so particularly with cancer services, so that's seen as an integrated pathway. So I can pick up any questions in a moment if anyone has from that. The Denny review, I think people are aware of. There is a letter that's been written to all organisations seeking their commitment that Rima and Felicity, Chair and Chief Exec, have written. In fact, it came out today. The other element just to raise, and it's on the agenda, is update on mental health, learning disability and autism collaborative. So that's good. We'll have that anyway. In governance terms, for Luton, there's no change, and clearly with yourself and colleagues here to be on that integrated care partnership. And again, this thing called the target operating model, it is a staff consultation that the consultation has ended, but we're going through the process. The process at the moment is pooling, whereby staff job descriptions are matched. And again, just to give that clarity to colleagues, that the target operating model is about being really agile and responsive to place, so particularly with Luton. So there are sort of 3 tiers. They're all part of the integrated care board, but what we're calling the core element, an element called shared transformation, and then an element of place. And that has been shared. But again, if anyone has any questions, happy to take those. But that's the highlight.
Thank you, Nikki. Are there any questions? Yes, Tutor.
The Denny review. Yes, we see it as a document, and you explained that you'll be getting organisations to sign up to it. But how are we going to actually see the improvements in health in terms of what's come out of the review? How are we going to be able to measure that from organisations just not signing up to it? You can sign up to it, but do we actually know what changes that will be made within the organisations to align us with what's come out of the review?
Yeah, thank you for that question. That is the work that is in train, and the letter that Rima and Felicity is actually specifying that, the short and the longer terms. So I think probably better we have a really focused session on that. The points you raise are absolutely being identified in the sense, how do we know we've made a difference? I think, and I know Sally, Mark and myself have spoken, the findings of Denny are absolutely completely complementary to the work of Marmot and the stuff that we're dealing with. But point well made, but I can't answer in detail, but we'll get that. If we have that onto the agenda, we'll really pick up, how do we know when we've made a difference?
Thanks, Reverend Denny, to come along as well, as he led on the report to a future meeting of Health and Wellbeing Board. Yeah, sorry, Nina.
Yes, I would endorse that view, and I think because as Councillor Malik said, there's the understanding the Denny report, which some of us have had sight of and read ahead of time. I would hope it gets a very public launch, and I know that with the by-elections going on, there was a sort of holding back until that position. But then it's the so what, isn't it? So what difference is there, and how do we know it's made a difference? And from my point of view as a clinician, one of the big things for me is about how are my patients that I've referred into other services managed, and how are they being prioritised with understanding of their inequalities that they are suffering from and they're subject to, which then makes a difference to their time on the waiting list or the support to get to appointments, etc., etc. There's all sorts of ramifications to this, some of which will be quite simple to put into place. However, you've got to think about it. So I think it's the so what happens, and which would be really good to actually get into the detail of at a future session.
I mean, if you are looking at elements of the report, and as organisations can see where they can make a difference. So clearly in primary care, one of the areas of findings was homelessness and people being rejected by the frontline reception staff. So we can all do a lot now. We don't need to wait for other things to happen. So for example, in that basis, I can confirm there's reception staff training. We call them care navigators, because if we've only got one person that doesn't treat somebody with respect and kindness and helping, we could have the 26 other front desks all doing the right thing. So it's making sure there's not a weak link at all in anywhere. So again, really point well made, and I think it will be a lot of with Reverend Denny saying what he found, and basically you have to repeat the exercise and see if it's an improvement at some point.
Thank you. I think what would really concern me is that we get this is just one of the reviews. around and around the work and inequalities around Luton. And I think Health Watch, we have the university, there's so much research that's done. And I think the most frustration that I have is that the work is done there, but then we already know the inequalities and we know some of the things that are, but then there's nothing actually done. And that's when communities lose trust in us. And, it says in here that, they were able to do great work and we were able to engage with them. I think for me, it's around that. How are we able to then measure back, and how is it going to be reported back to us to see that these are the changes that have been made? And it is around working together in partnership and, working together to do that. But I think what's really important is what changes that have been made after the review has taken place around inequalities, and around health issues that have been addressed in this report. And I think that is what I would like to see back here, to say that part of the review that took place, how are we measuring that? Because we don't want to say we're endorsing the report, we've seen it, that's fine, and we go away and we come back again and we say, yes, we're doing another review now, and I think we've had enough reviews now. It's time we saw some action.
Fair comment. Okay, so we'll arrange for Reverend Denny and to have a whole session on the Denny report. Okay. Any other questions on the report before us? Yes, Nina.
This is a sort of slight side issue, really, but so this talks about the operating model and the structure around the Integrated Care Board, which is helpful to be laid out. The other bit for me is, which I seem to have lost sight of now, is the clinical strategy. So again, there were consultations on the clinical strategy. Where does that fit into this? And when are we going to hear more about the outcomes of that consultation on the clinical strategy? Because it talks about the medical directorate, it talks about the clinical senate, but actually there's the so what. The clinical strategy is part of the so what.
So Sarah Whiteman is the SRO, and that has been to the board. So we can certainly share the latest slides, and it is work in progress. I'm just looking at Sally as a co-member. I think that came to the board a couple of about 3 months ago. Again, we could pick that up for the next report, so focus on that for you.
Because there was very much something that I thought was missing. But whether that's actually been agreed, whether it was post-board or whether it's was pre-board that consultation happened. But there's some critical areas of service delivery that are causing major problems for primary care and for residents that we were trying to get into that clinical strategy. And as I say, I've seen nothing since.
Very happy to do a one-to-one to pick up your key points, but I can certainly share the slides where there's agreed priorities. Okay.
I've never done this before, so excuse me. I just wanted to come back to Councillor Malik first and then just ask Nikki a question, if that was all right. So with regards to Denny, obviously the Health Watch cross BLMK supported that engagement, and the ICB will run with that action plan. They are creating an action plan, but all Health Watch have said the engagement actually took place in 2022. We're not that far off from 2024, so there will be a case of working through and revisiting what has been said in that report and the findings. But I think mostly Health Watch and the ICB said in that report, it's the start of a conversation. And I think the fact that it is embedding in a lot of the programmes across the board, I keep hearing about the Denny report, whether I agree with all of them or not, the fact that it is being spoken about for me is much further on than where we were before. But you are right, and part of our role will be holding them to account and making sure that that action plan does go forward. From the target operating model, Nikki, I just wanted to know really, because I've been a bit out of the loop, but really 30% reduction in staff at the ICB. And I think Phil said that he'd been to a King's Fund meeting recently where they were talking about going back to place. And I was just wondering how programmes of work are going to continue running when we've gone out sort of regionally, BLMK wide. Now they're coming back to place. Has there been a review of how things have been managed or how better it will be coming back to Luton and Bedford Borough?
So is your reference to is your question reference to the specialist commission I mentioned? Okay, so really helpful question to distinguish between the two. So in our target operating model, we're very aware that the specialist commissioning we're taking to host. So because that is a hosting arrangement for all of the region, it will be in effect a side family in the. So it's not going to be, that element won't be embedded into our target operating model because they've got to represent the region. However, so they will have their own finance lead, their own program lead, and their own governance reporting board. Okay, I think what the really important thing, and if you, and again, happy to talk through in detail with anybody on a one-to-one, but if you look at the target operating model and particularly the place resource, it's increasingly making sure that we're working to the place objectives and supporting that, so that there's not an ICB and place. In effect, we are 4 places, and in this case we're talking about Luton. These are the priorities and what do we need to take place. So for example, if Mark's got some specific work where he's wanting something from the health to absolutely help to do some of the delivery of those objectives, we may use some of the resource from the shared transformation. So I think really the important thing is that those 3 layers I talk about need to be seen as one. And I'm the link director. There's other link directors which I think are named in the document. So it's how we keep that personalised patient focus and a place focus. You know, so it's all the tiered way up. And I suppose it's all about being responsive and agile, putting the resources to local areas. And I know Sarah Stanley is the SRO for the inequalities, working incredibly closely, particularly with Director of Public Health, but about where we're targeting our resources to meet inequalities in our BLNK. So we've had some tense discussions. It's not about divvying the money by the capitation across the BLNK. It's actually addressing where need is.
Yeah. Okay. Yeah. Okay. Are there any other questions on the report? Yes, Bill.
Sorry, I just got slightly confused. The King's Lund conference I went on, that sort of said that the specialist commissioning, which was previously held by NHS England, was being disseminated down to the ICB, but they believed that the ICBs would in the near future be disseminating some of the original commissioning back to place where it was more appropriate to do so.
And in effect, that has been the intention, and hopefully colleagues who've been close to the integrated care system that put the strategy, that's been it. We've said from the beginning, principle subsidiarity, put as much to the local residents to place, but at the same time, it's not making old PCGs or PCT. It's about where it makes sense. And again, we'll be very, very guided by Mark as to what is appropriate and what stays at an ICB scaled level.
There, Phil? Yeah. Anybody else? Are we happy to agree the recommendations? Yeah.
Thank you.
Thank you very much. We move on to item 9, the fuller stocktake update for Luton. Is that a double act, is it? Okay.
Yes. So I can start and then hand over to Nikki as needed. So this is a broad update on the fuller stocktake and the progress against that in Luton. So the fuller stocktake is a report written by a GP looking at primary care and demand, but thinking about that in the context of integrated care and how we work better as a system and manage health and care services. So there was a number of recommendations in there, and they broadly fall under 4 areas of work. So the report outlines against those 4 areas of work, progress and developments and current thinking for us in Luton on that. So the broad areas are around neighbourhood working, so thinking about agile teams connected to residents working in neighbourhood settings. The second area is same-day primary care. The third area is around proactive and personalised care for populations with comorbidities, and then the last one is around an approach to illness prevention. So just in terms of the neighbourhood working, first of all, we have initially done a lot of sort of desk-based work, really looking at what neighbourhoods could look like for us in Luton, taking into account the recommendations in the Fuller report around size of neighbourhoods and thinking about geographical areas rather than so thinking about actually kind of where roads are and how the logical split for a geographical area. So we've come up with a proposal of 5 neighbourhoods and done some mapping around assets and what's already in those neighbourhoods. And we've held a workshop which had some broad system input into discussions around what that could mean for services, what it could look like, how it would interplay with PCNs and current structures of other organisations and direction of travel. There were outcomes from the workshop which we are still yet to pull back together and say, right, what does this mean now for next steps? But I've just laid out in the report some key strengths and weaknesses and discussion points that came out from the workshop, and then some proposed next steps, which we then need to pull back together in terms of how do we then take it forward. We have had some further smaller scale discussions around some of the additional inequalities funding that's coming from the ICB into place to say how can we help this to pump prime some of the thinking around neighbourhoods. So that's getting moved forwards. And then I think we need to really think about with in the context of what Nikki's just said around the updates around ICB and coming to place and how we work through what happens next in terms of the leadership and how we develop this work. So it's an ongoing piece of work and happy to take questions and comments and discussion on that, but it is still quite developmental. And then in terms of the report for primary care access and the personalised care, shall I hand over to you, Nikki, just for any key updates on that area?
Yeah, of course. I just want to raise that when we're talking about primary care, we are talking about community pharmacists, dentists and optometrists as well as GPs. So I've got to really try and emphasise it. And we are talking about a 24/7 offer. It's not just daytime. So clearly primary care access remains a monumental, probably the biggest issue because it is, I call it the front door into their health and care services. So increasingly, probably the biggest area has been getting through onto the telephone. So there's been a big push about what we call cloud-based telephony. I mean, we've got Nina here as one of the PCN CDs, but it's very much about how we work with the practices and the PCNs to help residents see what the offer is for primary care. So we've divided it for sort of convenience purposes to people who need same day access and for what we call proactive personalised care. So all of the practices are working really hard on identifying the vulnerable patients, particularly with long-term conditions, to do that proactive. So ideally, if you've got proactive care plans and you've got some care managers, those people shouldn't be fighting for the appointments, as we hear on the radio and we hear locally of people not being able to get through. I think the other bit is in Luton, we do particularly well on online prescriptions of actually people using the online app. So that takes a bit away the pressure. But it is still a challenge, and we know it's a challenge. Some practices do better than others. Some PCNs do better than others. And, I don't want to put words into Nina's mouth, but we are encouraging the practices to support good work with each other. And there's a fair bit of facilitated work that's at a local and at a national level. So, for example, the frontline staff going on courses, getting that training. And the biggest thing is about that skill mix within practices. And do I dare say it's about how we help the residents manage expectations so that if you see a paramedic or a social prescriber or a nurse or a pharmacist, there is not that feeling of people not feeling shortchanged that they haven't seen the GP. So they are the big areas we're working with. I think it's fair to say that the integration of 111 with the 999 and the proactive work. So there's something you will have heard called virtual wards. The virtual wards at the moment tends to be people coming out of often it's acute, sometimes it can be mental health, but onto those virtual wards. But what we're trying to work on is working with primary care, particularly GP practices, to those vulnerable people, and that's very much with our community providers. And I can see on screen, Anita, how we're working in that really proactive way. It is to try and help take that demand. So it's a whole systems approach to that primary care access piece. And then the final bit that I think is probably the most important is our prevention work. So in fairness, yesterday was a really good example of getting, community active, walking, running, spectating, because the inactivity, probably the biggest thing for our residents in Luton. And there's a prevention plan which we'll be in a position to share with the Health and Wellbeing Board, very much co-designed with local community residents, particularly support of public health, and facilitated by the prevention team in the ICB. So it hopefully gives that feel that what I call integrated approach. And the very final thing, and I'll just pick up because I've had many questions about how do primary care networks, how does it work with neighbourhoods? So we are really, really clear that no resident in Luton should see any boundaries. All they need to know is ideally which practice they're registered at, so that they know where they get their primary care services. And it's how we all work collectively together to give the right offer to our residents. And I think, as you quite rightly say, we don't claim that that's in any way resolved, but we're on that journey together.
Thank you, Nikki. Okay, open for questions. Phil.
Regarding analog telephony and digital telephony or cloud-based, there are still a number of practices in Luton which are on analog and haven't moved to digital. Now, the last time I raised this at somewhere or other, the money had run out from the ICB to support it. Is there now funds there so that all the practices in Luton can go to cloud-based telephony? Because, what we hear is it certainly reduces the frustration of people waiting to get through.
Yes, and I've found my page avidly. So we have 16 practices that have moved to 16 practices that are already on cloud-based telephony, and we have 7 that are on analog moving. There is funding for all of those, so that will happen. I am confident that will happen by the 31st of January, although we're aiming for the 31st of December. But I'm giving the commitment for March. I'm less confident for the December, or that could happen. Of those 16, some of those practices had some of the earlier cloud-based. So if there's any funding, and there may be, we'll do some upgrading of some of those. And I have to say, that's been the national team have been supporting. So confident on that one.
Anybody else? Yes, Lucy.
Sorry, Nikki. Reading the report, so I do get about managing expectations, but we've talked about 24/7 access for a while. I couldn't see anywhere in the report about health education out to the Luton public. People still feel the reason why we get GP access as the largest thing is they're still waiting to get hold of their GP. That education, I don't think, has filtered out maybe down to many of the residents that we're speaking to. So I just wondered if that's going to be part of the neighbourhood fuller approach, and potentially the money coming down from the ICBs to develop the BCNs should be around health education for residents.
So I think an absolute avid point, and I know that the comms team are very much supporting, but that is something, and I think through the most recent, it was about August time, we did something with the People and Communities Board, but absolutely we need to do that with yourselves and equally community voluntary sector. But yeah, the team have got that. But again, we have to just keep reiterating it. It will be an ongoing educational about, how we use the services. But I think, Lucy, your point is a good one, is that the services have changed for the average people, and we haven't made it clear. So again, very, very valid point, and that needs to be the focus.
Can I come in? Sorry, just when the reporting, it says about primary care access, but at the beginning we sort of said about that included dental optometry. There's not much reference to dental access, which is an increasing issue. So I just wondered if that's part of the confusion. Is when I read this report, I read primary care access and it talks about 62 practices. Is that including the dental?
So you're absolutely right, and within this report. So I can certainly give you, only that I've had to this week do a report to NHS England. So very, very happy to give you what I've just called my 9-point summary, because there's quite a lot of good work that's taken place particularly in Luton on the dentistry element. Again, it's about managing expectations. It is a national contract that, and I don't mind being quoted, isn't fit for purpose. But we have a biopsy service that's gone live within Luton that actually try and take some of the unnecessary need for secondary care. We've equally got some access pilot specifically at Luton at vulnerable groups. So I'll give you a summary of it, but you're absolutely right. In fairness, when you're doing these reports and its speed, so we ought to put, there is a separate addendum for dentistry, but this really was the workshop we had at the early September to say about how we're working together to try and make it, if I'm really honest, it's still access and personalisation that's the focus.
So building on that, does everyone know about the technology and the ways of contacting and indeed that proactive work? I think it's going to needs to be a major and ongoing programme. And I was just talking to someone from the local authority this morning about the need for the local authority to know stuff and communicating with practices, and then, which is the most appropriate source of information. And, there's things like NHS app. How many existing health staff have the NHS app? Never mind staff in all sorts of other arenas. Perhaps that's a programme that we need to promote, because you then realise what can be done on the app and therefore can help others to use easy access 24/7. You can do that while you're watching the telly, whatever. And then also to promote the online consultations. It's not for everyone. We recognise it's not for everyone, but someone can do it on someone's behalf. Someone can communicate on someone's behalf. Then the action that takes place is in a sort of planned way in the background and doesn't involve the phone system. So I think there's all sorts of pieces of the ways of working that people don't know and haven't had the chance to practice with. And if you get a good experience with a new bit of kit, then obviously you'll use it again. And we just need to make sure that we spread all of those things. But I think there's a lot we as individuals could do in terms of promoting some of these initiatives to our colleagues and then obviously to the residents that we're supporting.
So we do have the 31st of this month is one of our milestones for all of the practices to make retrospective notes available to residents. So technically from the 1st of November, if we've got compliance, but we'll work on it if we haven't on the 1st of November, so that it will be, you can access your notes from that date onwards. There was agreement, it wasn't prior to that which I won't go into. That then starts making it much easier. So you should be able to, for example, if you've had some test results, be able to use your app to actually look at it. So that is a programme that is taking place as we speak, a mix between colleagues in digital primary care and the comms team. There's some work that is not straightforward as I thought it was going to be. It's about being able to book appointments using the app. I do emphasise that we are the customers of the app. That's what I keep saying, is the NHS app is a sort of national thing, but we are in touch with the team so that what we would like with it. If anybody here hasn't downloaded the app, I'm actually now skilled enough to be able to show you how you do it. It would be really, really good for all of us here to just be role models before the next meeting, just to have a look at it, because there's quite a bit of prevention on there. There's quite a bit of like couch to 5 K running on there. So almost for us to become sort of critiques, and we can feed that through. But I would, by the next meeting, my expectation is all of our practices will be able to see those, which I think should be a game changer.
Just make a comment that maybe there's a pre that sort of thing conversation that needs to happen with our communities who don't understand the changes, don't get it, don't talk about it, they just moan because that's all they can do. They've got no way of understanding. And I'm sure there's ways we as councillors could work with you on trying to get some of those messages out, because we have community meetings and events. We would very much like to help you and help our residents to understand what's happening to primary care, the changes that are in there. The messages about the dentistry be really useful to understand what that is that we can tell residents who come to us because they can't get a dentist. So the more we work together, I think, on that, before we get to the app bit, on talking to people just about changes that are happening that aren't going to alter. The changes are going to stay, and you need to understand them and move with them. So maybe we could talk offline from here about how we might work with you in a better way. Yeah. Kachita, you were next. So
Thank you. I think expectation, and then coming out of COVID, you know, people that weren't able to see GPs or get into practices to get appointments, I think it's still ongoing. And I think I raised this before, it's about communication. And Hazel's absolutely right. Unless the community know, because me being on the health and wellbeing board, sometimes it's hard for me to understand exactly where and what we're happening. So you can imagine the communities that either don't have digital or have to rely on other people to get appointments. And I think it's a difference between dentistry and because most recently I was speaking to somebody and several different people talking about different practices, some doing amazing work and being able to access and see GPs and go through their need and understanding where they need to go next time they have a minor issue or they can see a pharmacist, etc. And other people really not even being able to get through the door. And that's the frustration, because it's a different thing not knowing why you need to go there. But then we've got, you don't want to miss something if it's really serious and you think it could be something that you need to see a GP about. So when people are rightfully concerned, they want to be able to see a GP. And if they're not able to access that and not get an appointment, even like today, then, you know, really it's not about education at all, is it? It's about access to the practice. So I think it's a difference between maybe a need that you may have, or you may be able to see a pharmacist for a little cold or flu or whatever it is, and then not being able to go. And so the educational part, I'm taking it offline, is really important about communities to understand that, you know, that if it is real need and you really feel it is, they shouldn't be put away by the fact that actually you can just go to the pharmacist because you really seriously think that you may have an issue. Yeah. So I think I understand that, you know, we talk about people's expectations, but yes, we will have those people that do expect to see a GP all the time and it's not possible. Yeah, so they need to know the other avenues and where they're able to go and access something, where they can go for a blood test. It's not just your GPs, you know, you can go here, etc. Not the burden, however. But I really think that education and really getting out the message to communities and different people to know where they can go for something which is serious and where they need to go if it's something minor. Dentist is another one still, you know. Regardless of that, we wouldn't be hearing some of these stories around people having to go to Turkey or other places to go and receive dental appointments. Even most recently, I came across somebody who called me and said to me, shall I just take this tooth out myself? Because it's causing me so much problem and I can't get an appointment, like I was able to get one for him. Do you know what I mean? So they are the real issues we have at the moment, regardless of education. you know, being able to see somebody to then signpost you off somewhere else. Sometimes you need to see a GP to have that reassurance. So I think, how is it that we're going to be able to have, it shouldn't be that I live in a certain place and my GP is this one and he's really, really good and he sees me. That access should be okay for you to go to any GP anywhere, for you to be able to go in and have that same service that I'm able to get with my GP. You know, is there a balance? Are we going to be able to see that practices are operating in, you know, a reasonable manner in terms of how do we check that? Because I'm still getting complaints from the community around particular practices where they're going to, and the access, or not being able to see somebody for a very long time and then just leaving it, and then they'll come through when it's late diagnosis and whatever there is. Because you know, really we should be able to educate people to be there and be able to see somebody for the prevention, rather than be at the later stage of, you know, a service that they may need to be using for longer.
I'm not going to fix it tomorrow for you, Khadija, because I can't. What I would say is that I'm the access lead representing Central Bedfordshire, because my practice has got some interest in Central Bedfordshire, so overall, we've not got universal, consistent capacity as we would like it to be across Luton, and there is variation. I'm not denying that. There's a lot less variation now than when there was when I first arrived 20 years ago, and I think the consistent offer is better in Luton than it is for what I'm experiencing in Central Bedfordshire. So there's a national problem, there's a local problem, and we need to keep narrowing that gap of variation. The other factor that we're also working on is trying to reduce the stuff that comes to general practice as a result of it not happening somewhere else. Okay, so a check we did in my practice about 4 or 5 months ago, 25% of the demand coming in on the phones and on the queries was actually because something hadn't happened in secondary care, mental health, or MSK. So actually, if all of that was working smoothly and all the capacity was there, you suddenly release 25% of activity to be dealing with the things that only GPs should be dealing with. So it's a system problem as well as the individual practices. But what I would say is there's a massive programme and some real clinical clout around trying to narrow that variation. But it's always going to be work in progress.
Okay.
Thank you, Chair. I have 3 questions and a statement, a comment actually. I'll go with the comment first. I think there is an error on page 85, paragraph 25. Error bookmark not defined. I'm assuming that's an error or typo. Yeah, so on there's twice on 1, 2, 7th line as well. Okay, so the question are from the workshop. There's on the table with strength, risk, and proposed next steps. My question is, who's leading those next steps? Is there a plan, timeline when these will start to happen? And what is these community roles? Can you explain that to me, please?
Yeah, the error is just where there was a reference put in and it's not been pulled through properly. So apologies for that. In terms of the proposed next step, so we're sort of shaping it as we go. So it's not, we haven't absolutely sort of nailed these, but recognising that there does need to be some leadership here. So between myself and Nikki particularly, we're sort of in discussion around this. So establishing that leadership and coordination for how we take this forward is part of our discussions still. We do have some additional opportunities with the Luton team as part of the ICB sort of supporting in some of these conversations. So as that progresses, we'll be able to think about it in that way. But at the moment, it's sort of still in fluid discussions around how we have that leadership, but not really sort of dictating how it works, because it's all us in the system working together on this. So we're sort of still working that through. The formal network for community roles is again just a proposed next step and a thought around that. But when we've had discussions about some of this work, there's a recognition there's a lot of, I've called them community roles in this paper, but it's people like social prescribing link workers, community connectors. There's quite a few in primary care networks that have that kind of community care connection role. So recognising that there's quite a lot of those roles and it can be a bit confusing, and there may possibly be some duplication or some lack of awareness of each other, I think it would make sense to establish a bit more of a formal network of those types of roles so they can connect to each other better and know what each other are doing. And we've started a bit of that through the Talk, Listen, Change research that we've done, where we've had a follow-up session where we particularly invited those types of roles to start thinking about how they can embed some of the Talk, Listen, Change research findings into what they're doing, but just building on that to try and formalise it a bit more so that they have maybe 6 monthly meetings and all come together and make sure that they know what each other are doing. That was the thinking there. But again, there's no absolutely firm plan on that. And similarly, if they all came together, making sure that everybody is aware of the online offers that they can be talking to patients about, thinking about how they can refer to each other, thinking about making sure that they are talking to the community in a health coaching kind of way, so that they're using interviewing techniques that make sure that people are motivated to make changes. So just making sure there's a sort of a bit of a standardized way of approaching that type of role was the thinking there.
I mean, thank you for that. I think it makes good sense to do that. Also, creating the voluntary sector alliance, because what Hazel and Councillor Malik said is it will feed into that, involving the community sector in there. So that's why I wanted to know what it was. Thank you.
Yeah, following up on Nina's point, actually mentioned by a few people about awareness and making people aware of what's available in the new methods. There was a 10-page, easy-to-read booklet which went through everybody's letterbox from the ICB 6 months ago now, plus possibly, which was an excellent booklet. And I've made the point a number of times that you might put it through people's letterboxes, but until you do that 3, 4, 5 or 6 times, they're not going to read it. And somebody did say there was going to be more promotion around that. I've not seen it, but that booklet was excellent in saying what was available, the new ways of working, etc., etc., etc. And just a second point, one of the things that we talk about is people going to the pharmacy rather than the doctor to get support. We have had feedback from the public about pharmacists saying we haven't got the capacity to do this, isolated, but so the pharmacies, people are being fed to the pharmacy and they haven't got the capacity to do that. A Healthwatch England conference I went on a couple of weeks ago, the person responsible for pharmacies in the UK or in England made the comment that pharmacies in England are closing down faster than high street pubs, which I guess is worrying on 2 scores.
Yeah, so as far as community pharmacy, call it the resilience of them, absolutely cited. Again, it goes back to some of the national contracts. So in fact, Rima and Felicity are quite well connected into that more strategic line. It is something we're not going to address at a local level, but we're feeding into it. But I think one of the other areas is, and that's about local commissioning, is about commissioning community pharmacists. So there's a lot of pilots taking place at the moment about some common conditions like urinary tract infection, insect bite. So, and in fact, we're piloting some of those in Luton. So, and then the other part of it is that I think it's by 2024, all pharmacists graduating will be independent prescribers. And we're doing a lot of work, particularly reliant on GP practices with GPs as being supervisors for pharmacists who are currently working that want to gain that qualification as a postgraduate. So there is a whole plethora of work equally. And in fact, Nina is also part of the primary care training hub, but of actually providing clinical placements for undergraduate pharmacists, and it may make them interested in, staying in the system. So absolutely cited, haven't got any solutions to it, but where we can make influence, we are.
Hello, good evening. I have a question to Sally. From my experience, I have seen especially extended service and 111 service. They are not talking. They are not connecting with the main GP properly. Like when patient goes to extended service, they ask they requested patient to make another follow-up appointment for the local main GP. But sometimes the patient next day morning, they are not able to get appointment, even though it was recommended by 111 referrer or extended service referrer. So is there any pathway can set up for extended service clinician? They can internally refer the registered GP. So patient, they no need to wait for another appointment. So they can get automatic appointment, through the 111 prescriber or extended.
This is a
clinician.
bugbear for practitioners as well, because so there are certain situations. So there are different services. So there's an extended access service which is bringing extra capacity in Luton that is provided by a collaboration and run by Evexia, our federation. They absolutely communicate into the GP surgery, and they absolutely complete the episode of care as far as they are able to. Okay. But if you're talking about out of hours doctors or the urgent treatment centre, then the practitioners there, it can be that that you get this sort of go back to see your GP about this. Sometimes that's appropriate, sometimes it isn't, and partly it's about volume of work on the day, how extensively they've looked at the clinical records, what the patient's told them, etc., etc. So the important thing here is that actually interventions need to be based on the individual's need, not what they want. It's what do they need to happen. Okay, so someone might want a scan or want some blood test or something, but actually when you look at the clinical records, all appropriate things were done 3 weeks ago. So going round that cycle again is not in that individual's interests. Understanding it better and reassessing the symptoms might well be in their interests, but actually just repeating something. So I think there is a whole work stream around connecting all of those services together. And when we identify there's a problem, then the clinicians and managers go back around it to understand why there's a problem and can we make something different happen? Is it a communication problem? Is it a sharing issue with the records? Is it a clinical judgment? Is it the training of the individuals providing the services? And there's no universal answer on this, but we do have a methodology to try and identify them and reduce the number of occasions when that happens.
Sorry, yeah. Sorry. No, actually, the prescriber, they ask to make another appointment with the GP, with the registered GP. But the problem is, patient, they're not able to get an appointment for next day. So I'm just saying, can they refer internally and make the booked for the patient, rather than patient need to call and
I think
get the appointment.
This needs an offline conversation, really, because it depends on the situation. And as I say, it's a common one that happens to encourage somebody out of the room and manage risk. And it's not necessarily appropriate at all. So let's have an offline consultation about it.
Yes, one more last question to Sally about dentistry. So some of the dentists, they are not accepting anymore NHS patient. So what is where they will report if any dentist, they're not accepting any more NHS patient?
So sorry, your question is about dentists that are not basically accepting an NHS contract. So in fairness, there's not a huge amount. I can't make a private business, provide NHS services. But what we can do is, have negotiations and, try and find a solution. But if if a dentist chooses not to offer NHS services, there's almost nothing I can do, in fairness.
No, dentists, those who are already accepting patient, but they're not taking any more new patient, but they're providing service for existing patient, but they are not taking any new patient.
So I can certainly, again, have an offline conversation, because a dentist can't, they don't, unlike GPs, they don't have a list of patients. So if they have availability and somebody comes and they've got basically a slot, then they have to offer it to that particular patient. So again, let me have an offline conversation, because our access pilot that we've done in Luton should help to overcome, and I think it's Hazel's point, making sure people are aware of what's available.
Are there any other questions from anybody else? Yes, Lucy.
I think it's just adding to that health education part from that what the gentleman's just added. So we said last year that obviously the commissioning of dental care was coming down to the ICB, which everyone knew. And I know we're in a stabilising year at the moment. From a general public's point of view, they have no idea what goes on in this meeting or what happens and just decided from NHS England down to local. And I just think there hasn't been any education or information out to anyone about the dental process. I know we've gone offline now and gone back to dental, but it's a really important point, I think, because that's the reason why Healthwatch get contacted. The majority of the time is people don't understand the process of what you've just said, which is they are private practices with an NHS contract. There's a lot of things within that in itself that the general public don't know. All they know is that they are going to go to A&E if they've got a toothache. They are going to go and try any other route to sort of support themselves. So it's a really important point.
We did a section, did we not, with the ICS partnership, and I know that our comms team are working with various comms teams. But again, your point is absolutely well made, and I think it's the same theme as what we've said earlier. It's about helping residents to understand what's available. So good point.
Anybody else? Are we happy to agree the report then that's before us? Yes. Thank you. Okay, we move on to item 10, which I believe is a presentation, adult mental health strategy.
Hi, I'm Gabby Wolf. I'm a public health registrar in the public health team in Luton Council, and I'm going to do the presentation with Robin Campbell and let him introduce himself.
Yeah, Robin Campbell, Deputy Director of Integrated Care, East London NHS.
So we're going to talk about the adult mental health strategy and its plan for delivery with the BLMK Provider Collaborative. So we're going to just discuss briefly why we have the strategy, what it's trying to address, and what our priorities within the strategy are. And then Robin will talk through the introduction to the BLMK Mental Health, Learning Disability and Autism Collaborative, and what the collaborative and ELT are doing to address the priorities, and then go on to next steps and oversight of delivery. So BLMK ICB has a mental health strategy. So the feeling was that we need to have a Luton specific strategy. And the reasons behind it, obviously the reasons I'm sure everyone here is aware of, the differences between Luton and compared to Bedford and Central Bedfordshire. For example, the ethnic diversity, which is obviously a strength for Luton, but also needs to be taken into consideration when developing models of care. And as you can see that despite Luton's diversity, actually looking at, for example, our IAPT services, they're being accessed by predominantly white British population. Admittedly, this is older data, but the pattern is still there, and it is less accessed by those from other ethnic groups. Another reason is obviously around the deprivation within Luton compared to other parts of BLMK. Recognising that children and adults who live in the lowest 20% income brackets are 2 to 3 times more likely to develop mental health problems than those in the highest. So clearly we have different issues that we need to consider here. And this just shows those different domains of deprivation and how Luton ranks in them. Also to consider are the change in population over time and the projected growth of Luton, but particularly amongst the over 65 population, which is projected to grow by 36% over the next 20 years. And the demand for mental health services has been gradually increasing over time and is likely to continue to do so. And as we all know, COVID-19 has had a huge impact. As we saw, there's been a general increase in mental health need for services over time, but that has also been compounded by COVID-19 as well.
Thanks, Gabby. Yeah, so in terms of the kind of national picture of demand and need for mental health services, you can see some of the local data for Bedfordshire, Bedford Central, Bedfordshire and Luton. And you can see over the last 5 years, CMHT demand has continued to increase. Interestingly, for Luton, the need per 100,000 population from a CMHT perspective is actually lower than the neighbouring boroughs, council, sorry. That is actually different than when you look at the kind of crisis service demand and the inpatient demand, which shows that Luton then has the highest per population need, 100,000 population mental health weighted demand, which kind of shows that from a sort of prevention point of view, we've really got a lot more work to do and to really focus on that in the coming years, in particular in Luton. And effectively what's happening is that people are presenting much further down their kind of journey in terms of their mental health need. So that's certainly an issue that we need to address as part of this strategy. Slide, please. And as you can see here, the kind of combination of our kind of recent significant increases in demand is really starting to affect our inpatient services, and demand for inpatient services across Bedfordshire and Luton has outstripped our capacity and led to an increase in out-of-area placements. That's also having a wider impact in terms of on the system, because those waiting for an admission are often in A&E, which is increasing pressure on our A&E colleagues. So addressing our kind of flow in urgent and emergency care is also a kind of critical component of our work, and that we need to address in the strategy. And in particular, one of the areas that we're really looking to work on is our sort of step down flow into housing, and our capacity for placements is a critical issue over the coming years as well. Slide, please. Yeah, and this is this kind of also highlights the issue I mentioned a few minutes ago in terms of crisis resolution demand actually for Luton, and indeed A&E demand actually is comparable to our kind of neighbouring areas versus CMHT that wasn't. So I can move on to that. So one of the challenges that we're seeing kind of causing that is the increasing of acuity. So the number of informal admissions is dropping, i.e. the number of formal admissions is rising. And at the same time, our length of stay is increasing because of that. So it's both an issue around acuity as well as our kind of onward flow, and the number of service users that we are trying to kind of move on through the system has become challenged in recent months and years. Next slide, please.
So how have we developed our strategy? We've done this through a process of co-production and consultation. We've had the Reimagining Mental Health Collaborative, which is a collaborative of local authority, ICB, people with lived experience, carers, voluntary and community sector organisations. Started the initial co-development of the strategy, and I will go into that in a bit. But they've been constantly sort of reviewing and feeding back on the strategy development. We've also engaged with other departments within the local authority, mental health clinicians, and kind of the wider mental health services, people with lived experience and service users in other forums, faith groups, voluntary community sector organisations, housing organisations. The vision and the intended outcomes were co-produced by the Reimagining Mental Health Collaborative, and the vision the collaborative came up with was that Luton is a community where I feel listened to, believed, understood, and supported to become the person I want to be. And I don't know if you can read the other outcomes of people having a choice and control and feel empowered to make choices. People are able to build on their strengths and assets, and people are staying well and living the life they want to lead. In addition, the collaborative co-produced these principles which kind of underpin the strategy around working from a social model as a starting point, client and customer needs and wants put at the centre of the approach. The work is underpinned by a trauma-informed approach, so kind of thinking about less what's wrong with the individual and more what has happened to them. Being more aware of the power which is inherently present in most professional client relationships, being empowering the client, ensuring equal engagement of all agencies, listening to all voices, where necessary to redistribute resources, and having a collaborative multi-agency group to discuss and agree the services and resources which are needed, thinking about how things can be done differently and collectively agreeing outcomes. And out of this, we have two main priorities which came out, which is around prevention of mental health issues arising in the first place, and also the sort of secondary prevention, so preventing people from getting worse or going into crisis, and access to services. And these are some of the kind of the concepts that we consider very important as part of this strategy. So obviously being a health equity town, and the recognition of the importance of the social determinants of health within mental health. So these are some kind of sort of cartoons here to depict the importance of the social factors on mental health outcomes and the exposure to socioeconomic disadvantage and discrimination to mental health. And the psychosocial model, so that recognizing that it's, there's often what has happened to the person rather than the person itself, which has led to the issues. And this is kind of depicting the trauma-informed approach, which I mentioned earlier, using the power threat meaning framework. So how will the strategy address these priorities? So I'm not going to go into these are all in the paper, but these are some of the elements of prevention which we're focusing on around kind of mental health literacy and anti-stigma messages, awareness of services, and supporting organisations. Access, kind of thinking about how we can improve access and make sure that services are culturally appropriate for the population, ensuring there's no wrong door approach, ensuring there's good communication and working together, and thinking about transitions from child to adult services, improving the crisis care pathway, and ensuring staff are aware of how to access mental health support as well, recognising they're also important, their mental health is important as well. Within this, we also need to be considering two two key important areas that cut across both access and prevention, and that's integration of services and also quality and experience. So within integration, we obviously want to make sure that we're working together with different across organisations and across sectors, co-producing when improving services, making sure mental health and non-mental health services are better linked, ensuring there's good care coordination, ensuring there's fewer pathways but more joined up governance, leadership, and working closely with relevant other departments, thinking about the holistic care of the individual, and also ensuring that data is joined up as well. And then thinking about the quality of an experience and making sure that service users feel better and actually are satisfied by the care that they receive, that there's a personalised care approach, looking at evidence-based approaches and proven technology, and ensuring that kind of staff training is good, and ensuring that friends and family are able to input into care decisions. And then the strategies in the process of being it's going to be going through the process of being signed off by the council at the moment, going through the council consultation process, and then out for public consultation at the end of that, before coming back for final sign-off.
Thank you. This is one thing, having the strategy. The next thing is what we're going to do about delivering that and really getting on and going further and faster to really make a difference to people's outcomes. And one of the kind of key sort of transformation vehicles, both nationally and within the BLMK integrated care system, is the concept of the sort of provider collaborative, and in this case, the Bedfordshire, Luton, Milton Keynes Mental Health, Learning Disability and Autism Provider Collaborative. And a paper on the development of the collaborative went to the September ICB and is included in your papers, and goes into some detail on the purpose of the collaborative and the mobilisation process over the next few months in advance of full launch in April. What I'll do is I'll briefly summarise the kind of purpose. So the mental health programme across Bedfordshire, Luton and Milton Keynes has had significant growth in recent years and investment across our services. And our planning is, I think, probably fair to say, is more integrated and collaborative amongst our partners than ever before. But it's largely been driven by the NHS long-term plan, very kind of top down. And what this, in terms of where the money's spent, very kind of clear, you know, this is how you spend your money, this is the sort of roles you need. And what the collaborative and indeed the integrated care system sort of development provides us with is an opportunity to really think through how we work at system and indeed at place in Luton, to work in partnership to focus our resources where they are most needed, and to really tailor services according to local need. So the kind of collaborative is really about formalising our already well developed integrated working, but going beyond that and developing, extending our collaboration across each place so that we could go further and faster in delivering a true integrated approach to whole population planning. And we really want to focus on things like addressing, we absolutely need to focus on areas such as addressing unwarranted variation and inequality across our services and in our communities. We'll be working across our partnership, across BLMK, to improve resilience. For example, many of you will have heard of the recent opening of the Evergreen Ward. That's a BLMK offer that simply couldn't have been done individually. And we'll be really focusing on areas of specialisation where services are more fragile and where it makes more sense to do it across the system. And we'll also be really focusing on prevention and, wherever possible, supporting service users in community rather than in more restrictive environments. Next slide, please. Thank you. So the kind of key principles for the collaborative around making sure that we improve our outcomes and are based on evidence and in full collaboration between our service users and carers, and really making sure that kind of clinical leadership, service user leadership and carer leadership is present in everything that we do, which sort of flips it on its head from the kind of old NHS long-term plan kind of directives to kind of be much more about local decision making, and that the collaborative will kind of enable that. Allow us to make collective decisions at place and in Luton, and making sure that we're truly held accountable to what we're doing, driving down inequalities, as I said, and really working in partnership to kind of reimagine the way we approach commissioning across the system at scale and also at place, so that we're truly integrated, working in partnership with voluntary sector, primary care, and health and care partners. Next slide, please. So for Luton, there's really kind of priorities over the next few months is really kind of getting on and delivering against those actions. And we think we can go further and faster, as I've said. But there will also be some areas where we want to work system-wide, where we think there's benefits to do so, such as improving our all-age crisis pathway and through our emergency care board, and addressing the challenges that I highlighted earlier. We're very much doing that in partnership with all the kind of key stakeholders, looking to improve our flow at each stage of the pathway, as I mentioned earlier. And there's a list of other elements that I won't go through here and that are in the paper. Next slide, please. So I guess one of the critical things is it's all kind of about, one part of it is the kind of governance of the collaborative and setting up how we'll operate, but we're also really making sure that we're also learning by doing, and really accelerating our collaboration around the delivery of our existing programs. And that includes significant transformation through community mental health teams and working in partnership with voluntary sector. It includes the development of care navigators, supporting BAME clients to make sure that they don't fall through the kind of gaps, if you like, in services, and to make sure that they are able to access psychological support. We're working in partnership with Resolution to improve access and outcomes for people with mental health and drug and alcohol needs, where there's been previously barriers to access. And that names quite a few of the kind of areas that we're really focusing on again. We could share these slides so people can look through the detail afterwards. Next slide, please. And this is the last slide. So in terms of next steps, so you've kind of heard a lot about the kind of ambition of the strategy, what we're doing now. We really want to kind of get on and turn that strategy into a kind of clearly focused action plan that's developed with partners. We held a workshop back in July, which kind of developed the initial principles, and our next workshop will kind of finalise our approach around this, and will include local authority colleagues, health colleagues, primary care, voluntary sector, reimagining mental health, and of course service users, carers, professional and clinical leadership. We want to make sure that kind of action plan is really tight, focused on meaningful and achievable, deliverable actions that are going to truly make a difference. And the plan will be supported by the development of the operating model for the collaborative to make sure we take advantage of the opportunities that collaboration can have, and build on what's already there to really kind of go further and faster, as I've already outlined. The plan is to kind of bring this operating plan to the Luton Place boards in the coming months for sign off, and we'd be happy to bring the kind of next steps back to this committee as well. Thank you.
Thank you very much. Very full presentation. Okay, Nina first.
Thank you. So I'm GP with Leavale. We have 3 times the national average for people with serious mental illness. We look after people with who are homeless and temporary housing, and the drug and alcohol population, large proportion. So this all sounds great. I tend to feel I've heard it all before, because I've been around for 20 years and we've had these co-production things before. So it's, when is the difference going to happen? Coming back to what Dr. Councillor Alex said earlier on, how will we know that it's making a difference? So one of the key things for me is what measure will there be in the community mental health teams about the number of people that are turned away and sent back to their GP or back to the primary care link worker? Because it happens time and time again. I had a patient this afternoon, took longer than the consultation time, in great distress, who had already been referred and then was sent back to the primary care link worker. She is one person. She cannot manage all of these, and actually the doctor view was that she needed CMHT. So this happens time and time again. So I need something that shows that all those principles you've signed up to are actually being delivered in the interests of our residents. And if we can get that, everything else will flow from it. I absolutely fully endorse all of the prevention work. Absolutely, that needs to happen. But the people who are already in distress need to have an appropriate, timely response, not feel that they've been pushed off, which they often do. So if you can deliver that for me, I'd be happy.
I don't know if Michelle wants to come here to talk about the programme that we've got to address that.
Yeah, thanks, Nina. And I know we've had this conversation before, and I think, that's a fair measure, and I think we should take that away and look at the numbers. And actually, I'm happy to be with the outside and look and see what does that look and feel like. I think one of the things really for us in terms of the system is that 40% of the people that are going into A&E with mental health crisis are not known to us. So, and that's a really big challenge. And I from our point of view, if 40% of the people are going there for their mental health support, then the access isn't working in our community teams. So actually, what do we do differently to make sure that people access our services? The same like with the crisis, we have a crisis cafe in Luton, really low take up on that. And actually, when you think about that and that space compared to A&E, you would think most people would want to go to the crisis cafe. Again, there is something that we have to challenge ourselves around access. So very happy to take away, and let's look at some numbers around that in terms of the pushback, because that's not what we want to be doing. But I do think, there are some real things about access and challenge in our community that we could do a lot better about. So, and I'm sure we will be picking that up through the strategy work.
So just building on what Nina's saying there, when I looked through the report and I heard the presentation, I was left thinking, where do we want to be in 12 months' time? And actually, how do we know we've got there? We're going in the right direction. So I think it's a really key point, and we sound like we're starting to unpack. There's something there about maybe even you've spoken about addressing the priorities. I wonder if there's something we can put into that as some form of measure to give us a sense of success. That could be something to think about. There was some really interesting information. The next point is really interesting information by way of data. So those referrals and where they were coming from and the different groups. I did wonder if we were tracking them by area, and if there was anything we could map out by ward. I think that would be really helpful by way of distributing monies as we go forward as well. There's definitely something for me here about the root cause, what's driving mental health as a system, and how are you linking into those other services? As you say, people are turning up and they're not known, but they could be known to someone else. So how are we making those connections? And I think that's a really good success criteria as we go forward as well. Those are my 2 points.
So on that? Oh.
Sorry, I was just going to come back on that.
You're going to come.
So that we've had quite a few conversations around as part of this developing a dashboard. So I think that's still in the thinking, and we want to do that. And then I was also going to mention around that last bit about how could we have prevented things, and those people that are turning up in crisis that we didn't know that weren't known to services. That plays into, we're doing a piece of work looking at the population health management approach, so doing exactly that. So people with serious mental illness, what was their pathway prior to crisis, and what could we have done differently to prevent that. So it's a sort of longer term piece of work, but that is definitely part of what we're trying to do through that. Sorry, was there anything else? Yeah.
Well, just picking up on that as well, Sally, is there a connection here, obviously, when we're doing all of our work at place, how mental health then links its way into that and how it's sat within the place delivery model?
Do you mean the neighbourhoods?
Yeah,
work?
absolutely.
Yeah, so when we've had the neighbourhood workshop, Michelle was there and part of the discussions, yeah.
Sorry, yeah, I just wanted to come in on Nina's point, actually, because I think it was a really good point. I haven't been around as long as Nina, but I have been around long enough to know that mental health comes back around for Health Watch, so it's come up and down, same as GP access. But I think the other challenge for this board, I wondered, is that actually if we did get some data around where these people are coming from, but also we've had feedback on people going to their GP with mental health and being referred straight back out to talking therapies or otherwise. So I'd quite like to know the data of where their touch points are, how they are accessing. You talked about sort of a no wrong door, which I think you've worked on before, Phil, in the past, which has sort of been changed slightly. But I'd just quite like to follow the data really of who's going to the GPs and feeling like they're not getting anywhere and not getting referred, who's going to the GPs and getting referred to talking therapies and not the CMHT. It would just be a bit more interesting offline, maybe we could get more of that data. From you.
I think that we really do have an opportunity to systematically use data in a far better way. I guess it's data, but it's also the service user stories, isn't it? And the kind of the good and the bad stories that come out of that to really inform our decision making. One thing I said, I probably haven't quite been around as long in terms of kind of the way commissioning has changed, but 10 years ago working in Luton, some of the sort of data you look at was very, very primitive, shall I say, and really wasn't evidence-based in terms of how services should be planned. And I do really think now, with the way we are so data rich, we've got such great opportunities around we can cut data down to neighbourhoods and GPs, and we have got an opportunity really to brings our collective resource and intelligence together in a better way than I think we ever have done before. And I completely agree with you. It's definitely sometimes it feels like kind of Groundhog Day and going back round the roundabout. But I do think that this is an opportunity to kind of reset and do things differently, and maybe something that we haven't quite had before. And we've, I don't think we've got any choice but to really make the best of it, if I'm honest, because there's certainly, significant needs, and we've got to, really kind of crack on and try and make that difference. And if we aren't, call it out and make sure we've got the right systems to really challenge ourselves and hold ourselves to account.
So on that business of understanding why it's not working, for me as a practitioner and for my patients, our patients, we have established a wider MDT for mental health over the last few months, working with someone from Elft. It's been very beneficial to us. We've been bringing very complex individuals and some less complex individuals where it's not working for that person. The whole point of the reason that coming to discuss it is because it's not working for that person, and trying to work it out why. Why is it breaking down? Why is there a gap? Why are they, buffeting between different services? So we're trying to do the practical application of it, as well as you say, you start with the data, but actually it's the patient experience, it's the resident experience. So there's both of those happening. It wouldn't have happened if we didn't push hard to make it happen. But we can talk outside about, how do you get that intelligence from that kind of dialogue, and who else is in your team that's coming to that? Because I think it's very rich and there's some easily solvable issues, but it does require some probably capacity, but ultimately it's the ways of working. It's the ways of working, respecting the other professionals and the voluntary sector, and for what they're already doing. If they're saying we're at our limit, then actually that needs further action and into that team. You're getting them in crisis because actually that bit in the middle isn't functioning, and we're holding them inadequately.
Yes, just quickly, if that's okay. So I do think that it's a really helpful conversation, because about 18 months ago, we did a bit of a deep dive on some of the mental health service data, looking at, it was before your time, Jill, but looking at demand in adult social care and looking at where people were turning up in crisis. And I used an Elft analyst to help with that. And it took quite a long time for them to work through getting the data. And I just think it would be really helpful if, as a system, as part of this provider collaborative approach, we can just get better at sharing our analytical resource, so that we, somebody in my team can talk to your team and just get that data quickly, rather than it taking 3 months to extract it out. So I think if we can commit to that as a system, that would be really helpful.
And it would be really good to, have that conversation as well. I was previously a GP and encountered exactly kind of what you're saying. So I, absolutely appreciate that. That's, I was a GP quite a long time ago now, but it's, I think it's the same issues as you say are going round and round. And but yeah, I do recognise that, and I think it'd be good to have that chat.
Just the here and now, I'll link up with Robin and Michelle, because to any of our residents, they should be able to ring the 111 if they don't know where they're going, as a better alternative to A&E, because they will go through the clinical assessment where there's a mental health practitioner that is the front end of what we call the clinical assessment service. Just ring the number, it's the right person will take the call. And that's when it should go back into, for example, like the crisis cafe, because I think a lot of this is our residents don't know. So again, I think it is what Phil was saying about that leaflet, is that it's about your 111 through that directory of service. It guides you, and it's your point, Nina, any of the community voluntary sector. If it's an option, it goes on the directory of service. It's real time, you can turn it off. So that the important thing is that people aren't shunted to a place where there isn't capacity. So we'll link into that. And I think your point of the analyst, because it will be interesting if those people in A&E, if they're not known at psychiatric liaison, what was their journey? That's the only way we're going to actually pinpoint what the problems are.
Everybody, are there any more questions? Are we happy to agree the approach and direction of travel as recommended in the report? Yes? Thank you very much. Oh, sorry.
Yeah, I was just going to say, I think we do. We all agree the premise of the report and the priorities and everything we're doing from that perspective. I think we should sign it off with the understanding that we'll come back with those measures of actually understanding what's going to happen next 6 months, next 12 months. That'd be really helpful to just round it up. Thanks.
Is anybody online wanted to know?
I can't see a hand up, but oh, Anita. Anita, did you want to say something? Yeah.
Yes. Thank you, Chair. Yeah, I was just going to say to Gabby and also to Robin is I'll link up with you outside of here as well, because obviously we're the provider of all physical community health services for adults and children, and I think would be a key part of the intelligence gathering as well, of maybe where some of the users of the services may have, we could maybe help if we knew some further information that the collaborative was working on to signpost people in the right direction as well. So I'll link up with you, Robin, if that's all right, outside of here.
Thank you.
Thank you very much, Anita. Thank you. Anything else? We've got a second recommendation that Bert's written down. Yeah. Okay. Anything else from anybody? Okay. Thank you very much. We'll move on. Item 11, family hubs update. Who's doing that?
That's me.
Hi.
Okay. Michelle Bailey, Public Health Principal. You should have all had a quite a detailed update and a progress report. So I'm going to just pick out some highlights and then can answer any questions. So the progress report that's kind of attached in your papers is one that we are continually updating, and we use to update the Department of Education, our strategic partnership board, and all our sort of working groups. So we've got very robust sort of governance process with sort of a clear programme management and action logs and risk logs, and we've actually been sort of commended by the DFE, the Family Hub Network, and some of our partners. So just to kind of keep you updated on that. So part of the Family Hub programme is to develop a network of family hubs, so a mixture of sort of building-based and virtual spaces, and that network is sort of growing through our sort of multi-agency sort of partnership approach. I know lots of you will be interested in kind of the buildings that we've got, but is slightly more than that. But we have got this hub spoken outreach sort of model. So we've got two main sites at the moment. They're Parktown in the South Ward and Hockwell, which is in Leagrave Ward. And we've got some satellite sites at Pastures Way in Dalhousie and Fox Cubs, which is in Dallow, as well as lots of outreach across the town. And we're working with GPs, the voluntary sector, our libraries, our other anchor organisations, and lots of schools. So we're getting lots more people that want to be sort of part of the process. So the work with our sort of partners is helping us move from our 0 to 5, which we've had our focus on, to sort of that 0 to 19 or 0 to 25 for those children or young people that have got special educational needs. So that's helping us with our kind of that services without walls sort of approach. So it's not that the family hubs will be delivering all those 0 to 19 or 0 to 25 services. It's about bringing all those services together so our families and our children, our young people can access them more easily. So part of that approach is our digital sort of enhancements. So that will help sort of support our sort of physical model that we've got. We're just in the process of commissioning a digital solution. So that's a provider that can provide a website and an app. The website will have artificial intelligence to help families kind of find answers or be directed to the right services sort of there and then. It also has links to the NHS website and BBC Bite Size and Tiny Little Minds, and it can also sort of showcase certain sort of campaigns or health promotions and other apps as well. So earlier we were talking about kind of the use of the NHS app, so we could have that on there, so kind of families can access that, and also professionals will be able to kind of use that. We literally just appointed a provider today. Can't tell you who it is because we're still in sort of a bit of a standstill period, but the way that digital offer will work, we'll have a 3-month sort of proof of concept, so we'll have an opportunity to test that. Our families can test that, and then a 9-month implementation, and that was followed by like a 3-year license period. So really, really excited about that. So that will really hopefully help some of our families to have seamless access to services. As part of the programme, we're working with the University of Bedfordshire. We've reviewed sort of previous research. We had a research practice event last year, but the University of Bedfordshire are going to do some evaluation on the programme, but looking more at kind of transformation and system change. Some of our funded work stream areas, we've made significant progress in lots of them. We're very fortunate that we've got the foundations in Luton that are already there, that has enabled us to have quite a few integrated roles that are working across our partners, so Flying Star and Cambridge Community Services, so our 0 to 19 services, and also kind of ELFT and our CAMS teams. So we've got additional speech and language therapists, child assistant psychotherapists and assistant psychologists, and infant feeding team that's been sort of enhanced, so we've got like baby friendly leads there. So we're making really good progress on lots of areas there. Also in our funded work streams, we have to provide a Start for Life offer. I think that's on page 163, 164. So that's available digitally at the moment, and we've got some leaflets that are being tested with some of our parents and our families at the moment. So we've had lots of feedback. They really find it easy to follow. It is quite busy, but they like the roadmap effect. And then we're just working at how we can have that translated into different languages. But just on the kind of language element, some of our website that we've just commissioned will have like a recite function, so it'll be able to speak out loud, but it also translate into different languages. And the app, once it's downloaded on your phone, depending on what your settings are, your language settings, it will automatically translate on that. And then we've had a charity or organisation called Family Hubs Network that came and did a temperature check. We wanted an opportunity to kind of reflect on what we'd achieved and where, you know, our vision of where we were going. They came and visited Luton in July, and provided quite a few recommendations, but they noted kind of our our partnership working and our community involvement. So that was very, very, very helpful. And then our branding and our logo. So we've commissioned a company called Filigree, a creative agency that did the Step Forward Luton branding. And we wanted more than just for someone to be able to develop a logo for us. We wanted to be able to consult and co-design with our stakeholders and our families, but also come up with some opportunities of how we could communicate what a family hub is, what it meant to our families. So we had 6 designs that we reduced to 4, and then that's been out to focus groups and stakeholders, and there was one overwhelming third option, which if you look on page 177, we're almost at the final of this process with the agency. It's been really useful. Sorry. Oh, not 177. No, got it. Sorry, 182. Oh no, 177. I was right. Sorry. The second option, which is the H with lots of circles, is one that we are potentially going through, and that will have on the signage, it will have the Luton logo, which is on the posters. So and then just finally, we were just on the mental health strategy. We were talking about kind of how do we know we're making a difference. So we have been really looking at our outcomes and how we're evaluating the project. And we're developing an outcomes framework that's aligned to the Children's Trust Board priorities. So they cover the wellbeing of our children and our families, education and school readiness, and safeguarding and inequalities. And we've included kind of the parent and child voice in there. So that will help us to kind of measure where we're going and how we are making a difference to our families. So that's a whistle-stop tour of family hubs.
Very much for whistle top through the report. Thank you. Are there any questions on it for anybody? Yes, Lucy.
I just wanted to add from a Health Watch perspective, we've only just started to get involved, but it's been really interesting, I think, the process of how Michelle's been running the family hubs. There's obviously a lot of different ways that you can project manage something. I just think coming into some of the meetings that I've been into with the actual co-production and integration that she's got across span, I think it's a really great approach that she's taken so far. So I'm looking forward to seeing how they develop.
Thank you, Lucy. Anybody else?
Just if I
Yes.
can add to that as well. Yeah, just building on what Lucy's saying, I think Michelle and the team, this is a fabulous piece of work in a really, really short period of time as well. And what you've been able to mobilise, pull together, join people together, the co-production, absolutely first class. So thank you so much for everything you do.
Thank you very much. Unless there's anybody else, happy to agree with the recommendations.
Yes.
Thank you very much. Thank you. And we now move on to the Health Watch update. And I believe that's another presentation, am I right? No? Yeah.
Do I have to move?
No, you don't.
No. I don't know if I have to present. So Health Watch wanted to do a little bit of an update for you because I don't think we've been to Health and Wellbeing Board for a long, long time to present what we do and how we do it. So I'm hoping our presentation, which you've got in the pack, gives you a bit of information on the process of what Health Watch does and how we gather feedback and how we then create reports. I would really like to show some of you the detail of that in a lot more detail, which probably isn't right for here. But the overall ask, I think, was we were contacted earlier in the year by a private provider, which I appreciate there's a lot of private providers with NHS contracts. They didn't seem to know who Health Watch were. And they also threatened us with liable because we had feedback on our website, which was not very positive about their service. So we went and I think Phil's mentioned this past, and we've sort of dealt with that and it's all moved on. But it made me starting to think that we got our website in 2015 out of the Better Care Fund from some of the people around this table. And it was funded for Healthwatch to have a very open, transparent site on all services in Luton. And those services are listed on our website as front facing, and you can see people's positive and negative feedback on those services. And I think it was just something for us internally to review about whether that is still wanted. Healthwatch now fund it themselves. It's not funded by the Better Care Fund anymore. There are other ways in which we can gather feedback and display feedback. I think Phil and I have different approaches on this. I think I took the response from the provider as we were aggravating by showing and displaying publicly what people thought of services. Phil, I think you mentioned earlier that you might want to come in that actually it's quite transparent and it holds people to account and people can see what people think of the services. So the ask for the Health and Wellbeing Board is, did you want Healthwatch to continue to have that front-facing aspect? Is it still fit for purpose? Or can we have a discussion about another way? Did you want to add anything, Phil?
Timescales and stuff. I think the problem is when you ask people to feedback, you are predominantly going to get the negative feedback rather than the positive feedback. I see the front facing where those providers can see what the public think of their services as something they should look at positively and give them the opportunity to do something about it to increase their quality of service, if you like. I think we were talking earlier about the what's the other one that looks at hotels and things, Trustpilot or something, and I view it in the same way. And I think the unfortunate thing with the provider that started threatening legal action was their first thought was, we want them to stop saying that we're bad or stop putting that feedback on. Whereas our view was, well, why don't you look at that feedback and understand why you're getting that feedback and do something about it? And I see that as positive in influencing the service that providers provide to the public. If they don't like it, then tough, do something about it, is my view, not hide it. Is that strong enough for you, Lucy?
Yes, I agree to a point, but I just think, I would just like to have that conversation and a decision made. There is another way, which is Healthwatch England's approach, which they just have a form and an individual can still come to us online and say, I would like to give you feedback on this service. And then we collate it internally on the back end in front. The question is more, do we need the listed service? It means every single individual GP, every single dental practice, every single care home can come and not be happy about being front-faced and have feedback on them. I don't know who makes that decision. In 2015, 2016, it was a smaller group around a table that sort of decided that we had this. So I don't know who now decides that we don't or we do.
I would just add that it was only the second time in 8 years that we've had somebody complain at getting that negative feedback. So it wasn't a big issue. People threatening legal action that don't frighten me, to be perfectly honest. I've been through it before. But I see it as a positive and not a negative. And interestingly enough, I spoke to the quality person from Luton Borough Council who was on a system quality group that I raised this issue with. And when I was talking to her on the phone, she went onto the NHS England website at the patient feedback and looked and said, oh, you're right, they're dreadful. So that information is there on other sites as well. So I don't see that we're any different.
No, this sounds like an internal issue, like a married couple that can't make a decision, and it's really not. It genuinely is a question that the Health and Wellbeing Board paid for this service. So that's why we're coming back to you as a board to ask how you would like us as a Health Watch to carry on collecting information.
I think I tend to agree with Phil. Yeah, I think I do. I think it's worked up until now. And if you're saying we're not getting masses of complaints from providers, why would we change it? Unless you're recommending that there should be a change, Lucy. Yes, Jill.
I haven't necessarily got a choice either way, but I'm just thinking about sometimes those comments are a point in time, and they can sometimes, on any of these Trustpilot things, Airbnb or whatever, somebody had a bad experience. It's important to know that, but it could be a long time ago, and they get left on the website because nobody else has written anything since, positive or negative, and that's the last thing that you see. So I don't know how you deal with that kind of legacy comments, if you like, when things may have changed. But I also wondered, kind of like, as you say, there are other ways that this feedback can be utilised. And do we have any themed reports that can often be really helpful to say, in general, GP practices, for example, this is how patients rate them. However, there are some that are doing less well, not necessarily naming them, but then doing active work with those practices in partnership and collaboration to help improve those services, rather than create, potentially us and them, we, kind of divide line and think about how we can work, how Healthwatch can work more. I'm not saying you're not collaborative, but, in a collaborative way to drive up standards rather than exposing negativity in that way. Sometimes that can help get people on board rather than being defensive.
Anybody else's views? Yes, Nina.
I'm not sure whether I should express a view because I'm a provider and I'm sure, I know we get negative feedback. And as you say, you only get negative. People don't take the time to be positive. But it is what it is. And there are other sites as well. I was going to talk about the any provider of a service should recognise that there are others whose responsibility it is to give an overview or a route through which quality can be fed back. So actually, if the provider doesn't know about Healthwatch, that's their problem. And actually, that says something to me. And like I would know that there are NHS England sites and stuff like that. That's the responsibility of the provider, and whatever service you are providing, you should know where it's going to be looked at and assured. So, I think that is important to recognise that there is a responsibility from providers' point of view. I think there is something about moderating something. So, actually, if it's not acceptable, then it shouldn't be remain on the site. Is there something around a time frame? I don't know. I hadn't thought about it before, but maybe there is something about a time frame that actually things drop off after a while. You have certainly brought themes in the past, at appropriate intervals. And I think the other bit is actually, I know, but maybe others don't. You have the right to entry. And maybe and I'm glad you do, and that should remain. Do others know that? I don't know, but that is for them to know, I guess, really. So that would be my comments, really.
I think the time thing is an interesting one, and we may look at saying after 5 years or 3 years or something we remove. But the thing is, if you look at the web and you look at the comments, it tends to be the same complaint per provider. If they have something that they are unhappy with, it may be the receptionist attitude, it may be something else, but it tends to be a theme that runs through rather than a different thing on each one, if that makes sense. So it is something that the provider should look at to adjust to address.
Yeah, I mean, my view really supports Phil in the sense that it's been working up to now. I do think, and I hadn't thought of the points that Nina made, I think it's a really sensible, is about when things fall off, whatever time period. And of course, you would have the right to, you can see if something's vexatious or, whatever. But yeah, I think keep a status.
view is keep the status quo as we've got it now, but perhaps you could look at that, whether things get taken off after a period of time. Yeah, maybe that's something.
Each other after they raised the complaints saying how wonderful they were, we didn't put on.
I think it was a point also just to give you the sort of peace of mind that there is that authenticity, because I think
Yeah.
that was also challenged, and actually it was a really good piece of internal work for us to make sure that things were authentic in that way. But we can definitely look at that time frame for it and then keep it as it is. I mean,
I think I'd also like to thank Lucy when all this was blowing up. She was sitting on some sort of fair ride at Butlins or something and working hard on trying to address the issue.
Okay, any other questions on the report from anybody? Okay, you're happy to approve the status quo? Yeah. Okay, thank you. We now move on to the last report, and it's the work programme. It's normal recommendation there. Has anybody got any questions or anything on the work programme we want to discuss? No? We're happy to move the recommendations then. Thank you very much. And I think we're at the end of the agenda. Am I right there, Bert? Thank you very much, everybody, for your attendance and for a very full lot of information passed on to us this evening. Thank you very much. Yeah.
Thanks. Good night.